Okay, so we're going to talk about what happens when patients die both in the ER and in the hospital. There are a few things different about patient deaths in the emergency room. And they have to be handled a little bit differently than, let's say, somebody dying out on the floor. First thing is when a patient comes into the emergency room and they code either en route or while they're in the ER, there's a possibility that it could become a coroner's case. So after we're done and they're pronounced, then before anything is removed or the patient's cleaned up, patient's not even touched, you need to find out whether or not this patient is going to end up needing to have an autopsy. There are several ways of going about that. First is ask the police officer. So was there anything suspicious at the scene? Now obviously if the patient comes in with a gunshot to the head, something was suspicious. If the patient was a 20-year-old that was up here for ice fishing and was found out on the parking lot at 2 o'clock in the morning with a couple scrapes and a smudge along the side of his head, that's suspicious. So those would all be autopsies. You can also ask EMS when they picked up the patient, what was going on? Is this a trauma, like a penetrating trauma? What's the bruise pattern? Anything suspicious definitely warrants calling the police and or the coroner. Now, if this is a patient who's well known to the community, 90-year-old that's been doctoring at the clinic, and basically for the last 10 years everybody's been taking bets as to when he's going to end up dead versus not, and he comes in with death at home, that's not a coroner's case. It's not necessarily a call the police officer case, but you need to be very careful in those situations because it's better to err on the side of caution by calling possibly the police, who ought to probably, EMS usually notifies them of anything suspicious, and then they come in to check, because people have been known to euthanize their 90-year-old relatives due to various reasons. So if that is the case, you definitely want that taken care of correctly. So in the event that this patient is going to become a coroner's case by either the police have said it's suspicious, EMS indicates it's suspicious, you notice a suspicious injury pattern, or if unknown and we don't have anybody willing to sign a death certificate saying that, I, Dr. XYZ, declare that this patient died of a heart attack, they're also going to need an autopsy. So we go and call the North Dakota, it's on the gray sheet of numbers. It is under, I'm looking at it here, oh, here we go, MEUND Fargo Forensic Autopsy Facility. So we use the University of North Dakota, Fargo's pathology department, and their professors do our autopsies. So you call them, telephone number's there, you give them the information, someone will call you back, and then you give them the particulars. And then they, obviously if we need an autopsy, they're accepting the patient, and we will then send them to get that autopsy. In which case you remove nothing and you send along their chart, because they need to know when they're doing the autopsy, they need to account for medical treatment versus suspicious. So is that hole that's right over there due to a attempted IV stick, an attempted lab draw, or is that there because somebody gave them a shot of something that they then later died from? Once we find out whether or not they're going to be a forensic case, then we can call the organ procurement people, and we'll get into that in just a second. Now, if they are going to be an autopsy, if it's a suspicious death, according to the state, they look at the body as evidence. So chain of custody, you can't let people see the patient without having somebody beside them or with them. So it doesn't mean you can't let parents see them, but parents can't really touch and kiss them, that you need to guard against. If it's a police matter, make sure you clear it with the police officers before you let people in to see the patient. And that being said, you would then call the tissue donation people at LifeShare. Now there is a green folder. It is right there, and it's got the paperwork in it, because there's a little pack that you're going to use for the deaths. Right behind me is where it's at. It's up here at the top. Now this first page is kind of a check sheet for you to keep track of if you've gone through all the steps. Second sheet right here is part of the permanent record, goes in the chart, and it's got LifeSource's phone number, and just fill it out completely. There will be some revisions on this, but the important parts will remain the same. Now, once you call, you're going to talk to the operator, you're going to give them the information. You need to have the chart beside you, because they're going to ask you questions of which they would prefer you not have to look up. And then they will call you back. Right here, where it says, please document reference number, they're going to give you a number at the end of the call, the operator will. That has got to be written there. That is the proof that we have that we did our regulatory due diligence and did indeed consult organ procurement before we buried the patient. Because according to the United States law, each and every person that dies in the United States has a right to donate their organs. Now, when you call them up, you're going to give them the information that they asked for, which is basically allergies, diseases, what time did they die, what did they die from. Because we are not a tertiary care facility, we don't put people on ventilators, we're not going to actually probably have any organ donation. We have a lot of tissue donation or eye donation. They will call you back. A lot of times the operator will call you back and either decline for the tissue. Usually the eye people will call you themselves. Sometimes the operator will call you back with them. But that's two different phone calls from two different people. And sometimes it can take a while to get all of the yays and nays. They also need the phone number of the next of kin. This would be the person that's legally allowed to make decisions. So make sure that when you give them the wife's phone number, it's actually the wife and not the girlfriend of 20 years because they didn't get around to divorcing their wife of 40 years who still is a little bit upset about the whole event. And once we get the okay, meanwhile, while we're waiting for either the okay or we're going to pass on this, you need to make sure that we're keeping the body, especially the eyes, in a state that will be good for harvesting. So we do have little handouts on the floor about what to do, but you're going to put their head up slightly. You're going to and remember, especially for going to the funeral home, which we'll get into a little bit later, but you want the patient flat on their back. You want them in a neutral position for donation, slightly head up because you want the fluid to drain out of their eyes. You close their eyes, you tape their eyelids shut gently with some paper tape, put some ice packs on their face, keep them cool. If it's summer, put them in a room, turn the air conditioner all the way up, put some ice in the bed. Not necessarily in the bed, but in a bag in the bed. You don't want their skin macerated, but you want them to be kept cool. If the tissue if LifeSource decides that they're not a candidate for donation, they will let you know that, and at that point you can call Helgeson's. However, you do not approach the family, you let LifeSource do that. LifeSource gets quite upset if we approach the family first because sometimes they're not even a candidate, and we've had one case where they were very upset because the family was approached or they were told that someone from LifeSource would call them. They will not call them if they're not a candidate. Also, if the family like point blank asks you, like, John's always wanted to be donate his organs. He's talked about it a lot. Can he donate his organs? Just let them know that you'll make a few calls and you'll get back to them with that information. Let them know when you call that the family has asked that specific question, because they may then call them even if they're not a candidate, or they may just pass the message along. But you don't want to be in a position where you've promised the family something, because this is a very, very traumatic time for the family, and a lot of families look at donation as a way to keep part of their loved one alive or make something good of the situation. So you don't want them to have two losses in the same day. A loss of their loved one and then a loss of that anticipated gift. Now, should they decide that they are a donation candidate and they are going to harvest, LifeSource will set up the transport for themselves. They fly in on a fixed wing to our airport. If it's going to be a tissue donation, they like to use our OR if they can. If it's an eye donation, they can do that in the room. And they come from, I'm not sure where they come from, but I think they come out of two different places. Both, I think, are in North Dakota, however. So once we get that done, I'll call Helgeson's, or sometimes they'll call Helgeson's, because a lot of times if it's going to be a prolonged, especially with the eyes, I think they can actually harvest them over at Helgeson's also. And sometimes Helgeson will take them and then they'll bring them back for the harvesting. When this little piece of paper is all filled out, it goes in with the chart, which is your documentation that you have called, who you talked to, when you talked to them, and if they were a candidate or not a candidate. Now, that pretty much goes through the organ procurement process. Second thing would be deaths out on the floor. Since Helgeson's is pretty much the only place you're going to call, you still have to talk to the family, however, because you have to have all that information, next of kin, because Helgeson's will want to know that. When you call and let them know if they have any communicable diseases, you need to pass that along, or a high probability of, like this was a COVID patient, we were waiting on lab work to rule out Rift Valley fever, that kind of thing, so they can take the appropriate precautions. Make sure you take out all of the IVs, the Foleys, NG tube, that kind of stuff. If family wants to see them, clean them up, let the family spend some quiet time with them in a way that's meaningful to them. And give Helgeson some room because they like to go in there and do their funeral home thing. They need a little bit of space, so you want to kind of move the furniture for them so that they don't want it chaotic. They want very dignified, very respectful. So moving things around in a hurry is rather chaotic, and that's kind of not what you want. And they will come get the patient and they will get you to sign. Now, they're going to need a copy of the face sheet, and they will also bring a piece of paper that they will fill out that you have to sign, releasing that you release the body to them. And that's pretty much all there is to that aspect. Now, when the patient dies while we're waiting, because sometimes it can be a little bit even for Helgesons to come pick up the patient, bodies end up going into rigor, and they end up with this thing called lividity, which is when the blood settles out, which turns kind of a dark purple. You do not want the patient to be sitting straight up in the bed or have, on their face it turns bright purple, because there's not much they can do with purple for a funeral, and you do not want to be the one who caused a family even more grief by making them have to have a closed casket or something else that's going to stick in their mind forever. Also, when Helgesons puts them into the back of the vehicle, they can't be sitting straight up, and once rigor sets in, it's kind of hard to do anything with the body until rigor leaves, which takes quite a long time. In order to get a body to lay back down again. If it's in a odd position, you have to break the bones if you don't wait for rigor to leave the body. And again, that's traumatic, and you don't want to do that to a family. It's not respectful to the deceased. So you want them flat on their back. You want them in a neutral position as far as, you know, their head. You don't have to tape their eyes shut or anything like that, but try not to have them with their mouth gaping open. If they have false teeth, if you remember to talk to the family about it, go ahead. If not, they kind of leave them in, because you want the patient to look as natural as possible for their funeral. And all belongings that are still with the patient usually go with Helgesson's. Like we're talking watch, wallet usually. If it's a whole lot of things, try to send those home with the family. A lot of times the families will say, I'll come back and get them in the morning. In which case, just put them in a bag at the nurse's station with their name on it, and they'll pick it up. And that pretty much goes through everything. So to recap, death in the ER, rule out the fact that it has to go for an autopsy first and foremost. Do that by the police. If it shows up dead, already dead, you need to call the police, because they need to do an investigation. And that's by showing up dead, family member comes running in and saying, my mother is out in the car and I think she's dead. You would bring mother into the ER, call the police. Once we don't do anything else, remove anything, touch anything, till the police are done and we have ruled out the fact that they are going to be a coroner's case. That being done, the next thing you do is call Organ Share, or whatever Life Source, sorry. Organ Share is a different state. Life Source, and if they're going to be a coroner's case, let Life Source know that. That does not rule out tissue donation just because you're going to be a autopsy patient. Then after Life Source tells you what they're going to do, like yes, no, and even if they are a candidate, they have to talk to the family. So there's a lot of steps to this. Once you're sure that the patient is not going to be autopsied or go for tissue donation, then you call Helgesson so they can come pick up the patient. Even if if you find out that they are going to be a donor, then talk to Life Share about whether or not, or Life Source, whether or not they're going to call Helgesson's or if we should call Helgesson's. And if they're out on the floor and they die, make sure that you have let the family have as much time as they need. Get the patient cleaned up, remove medical devices, and make sure the patient is in a natural, neutral position. You can always put the head slightly up. They don't have to be flat in their back, but you don't want them sitting up at a 30 or 40 degree angle. And that's pretty much it.